speaking of research, Ron, I did mention to him, some of the question about palpation skills and our inter-rater and intra-rater reliability. He threw out some good research, which I'm glad he mentioned, so I can go back and look. Because my understanding was it pretty much fell apart with all. But I guess he's saying those that are trained in a specific aspect of palpation did show some inter or intra-rater reliability.
I would bet that's the case, and we know that is true in MDT as well, right? So if we look at comparing, or there were early study that was done by Riddle and Rothstein looking at PTs who were trained in MDT allegedly, comparing their inter-tester reliability in assessing a person. One person assessed the patient, and then the next person assessed the patient. Would they come to some agreement? But some had taken A, some had taken A through C, some had just read a pamphlet on MDT.
Yeah.
And in that pamphlet, it said at the end of reading this material, you'll be able to reliably differentiate patients. Because I asked Dr. Rothstein about that, and I said, how can you compare clinicians who have different levels of training? And he said, well, you should talk to your colleagues, because in that pamphlet, it said, following the reading of this pamphlet, you'll be able to differentiate classifications. And so subsequent research, Razamu and others have found that, the higher the amount of training, the better the intertester reliability. And that's probably true of any system. And when we have clinicians that can clinically reason, as Joe mentioned, when they can identify impairments and see how they relate to function and group that patient into a specific classification that has a specific treatment, the outcomes are favorable. And then you add on that therapeutic alliance in that Paris-trained clinician or Maitland-trained clinician or anyone who's trained at a high level in a specific approach probably has good outcomes with their patients. Mm-hmm. And I believe that to be true, and I know I've seen that in colleagues in AOMT who have different schools of thought, but in different ways of approaching different algorithm, but they have that systematic clinical reasoning, and they all have their biases, of course, right? So some are going to go toward the joint, some are going to go toward muscle imbalance, some towards trigger points, some towards repeated end range assessment. But when you're trained at a high level, you tend to do much better with the people you're seeing. So, and even though the number one predictor of outcome is that therapeutic alliance.
Yeah, so interesting. Yeah. Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.